This Block 1 workshop is titled Ketamine or Special K, What Makes a Drug a Medication? My name is Aleksandriva, and I'm a postdoc in psychiatry at the University of British Columbia and the coordinator for the MATRIX-N Research Cluster, which organized this conference. And it's my pleasure today to moderate this workshop and to welcome you all. To begin, I would like to acknowledge that UBC and Vancouver are situated on the traditional, ancestral, and unseceded territories of the Coast Salish peoples, including the Musqueam, the Squamish, and the Tsleil-Waututh nations. I am privileged to reside, learn, and work on this beautiful land. I immigrated to Canada from Bulgaria when I was 15 years old. And I continually strive to educate myself of Canada's colonial history and to reflect on my own experience as a settler here. And I know that many of you are joining us today from different places, near and far. So I encourage you to take a moment to acknowledge the traditional owners and caretakers of those lands. And please feel free to introduce yourself and where you're from in the chat. So now it's my pleasure to introduce our two speakers today, Dr. Christian Schütz and Dr. Raymond Lamb. So for an experimental or highly controlled drug to become an approved medication, certain research gaps need to be filled along the translational drug development pipeline. So Dr. Schütz will first present on providing rigorous clinical research evidence for ketamine in a new research indication, and in this case, substance use disorders. I will ask those joining us to mute themselves. I guess that doesn't happen automatically, but I'll keep an eye on it as well. So yes, he will present evidence on how to bridge this first translational gap between basic and clinical research, and the evidence for ketamine in a new indication like substance use disorders. So Dr. Christian Schütz is a practicing psychiatrist and a professor at UBC's Department of Psychiatry. He's the research and education medical manager at Redfish Healing Center for Mental Health and Addiction here in Vancouver. He holds an MD, a PhD in medical history, both from Germany, and a Master's of Public Health from Johns Hopkins University, with fellowships completed at NIDA and NIH, as well as Yale. His research interests include psychological and pharmacological interventions for individuals with substance use disorders, psychoneurobiological aspects of impulse decision-making, and substance use and concurrent disorders. So once Christian presents his slides for about 10-15 minutes, then Dr. Raymond Lamb will present on knowledge translation and implementation initiatives for IV ketamine for treatment-resistant depression into the community, or the second valley of death in the research to practice continuum. And Dr. Raymond Lamb is a professor and BC Leadership Chair in Depression Research in the Faculty of Medicine at the University of British Columbia and Associate Head of the UBC Department of Psychiatry. He is also co-director of the Mood Disorder Center at the DM Center for Brain Health in Vancouver, and a lead investigator for the Canadian Biomarkers Integration Network in Depression, or CanBind. Dr. Lamb's research examines clinical and neurobiological factors in seasonal treatment-resistant depression and workplace depression, biomarkers, clinical trials and guidelines, and digital health technologies. So please, as we hear from our speakers, drop any questions you have in the question and answer portion of the Whova platform on the right side of the screen, and I'll try to monitor the Zoom chat as well for any questions that are posted there. And we'll have some time for audience questions after the presentations. So please feel free to engage. And now I'd like to pass it on to Christian. We have his slides already, so Christian, please take it away.
Thank you very much, Lily. So my task was to talk about ketamine, or special K. One question was, what makes it medication? The second question was about the translational work and how well does ketamine work as a medication for alcohol use disorder. I do have a number of grants which are not directly conflicted. I'm on the advisory board for Clear Mind, which is a startup company looking actually at preclinical potential treatment for alcohol use disorder. It's not going forward, the slides. Let me see. Okay, so I already indicated that I first want to talk about the translational aspect, then a little bit about underlying mechanism, and then about the treatment development. I think most of you might be aware when it comes to development of new medication, there are it's a long way, and it starts with basic research, then we have clinical research, and then we try to transfer the clinical research into clinical practice. I will focus on the first two aspects, the basic research and the clinical research.
This is Kraus.
No.
Okay, so we have a so-called valley of death between the basic research and the clinical research for a number of reasons. And one is there's differences in the funding. The other is that a lot of medication do not translate easily into clinical research. And then there is also a huge investment if you do clinical research. I think Ray will talk more about the second valley of death, so I will keep it for short because there are a number of other topics I want to touch upon. One is how does alcohol act in the brain? This is actually not as easy as with other substance of abuse because alcohol is not a transmitter. Most other substances of abuse do act as transmitters, but alcohol molecules are actually too small to act as transmitters. So they do have an impact on transmitters, but it's an indirect impact. And it has impact on many transmitters, but the one where it has the biggest impact is glutamate. Glutamate is actually the transmitter which you find most in the brain. It's the transmitter which is responsible for the majority of the synaptic action. And you have to differentiate between two aspects. One is the acute effects on the synapses, and then you have changes on the synapses, synaptic plasticity, which leads to changes in the long-term effect of alcohol, such as tolerance and withdrawal symptoms. What you can see here is actually that the increased release of glutamate leads to a change in the synaptic composition, specifically among glutamate and glutamatergic receptors. So the focus of developing new medication has been to a big degree on glutamatergic receptors. But there's a second part in the cell. The synapses and the receptors are located on the cell membrane, but alcohol does not only act on the cell membrane, it also is active in the cytoplasm and in the nucleus. And in the nucleus, we have the genetic information, and activity on the cell membrane leads to changes in the genetic activity, so to say. Again, we have acute effects, which are immediately, but generally we have also changes in the overall, so to say, availability of the genetic information, which has received a lot of attention recently, so-called epigenetic effects and programming. And research in addiction actually has moved on from focusing mainly on the synaptic effects and plasma effects to look more at the combined plasma effects and also epigenetic effects. That's also one reason why one thing recently is happening, that there is an interest in repurposing cancer drugs for the treatment of substance use disorder. This is again the same. On the left-hand side, you have the glutamatergic receptor, which will activate intracellular signaling, and which will immediately, not immediately, eventually translate into transcription in the nucleus, and that again will change the overall intracellular signaling again, and will also change again the availability of the receptors at the cell membrane. With other words, what we have is changes, long-term changes, which lead to addiction on the synaptic level, which is more the memory enabling metaplasticity, the LTP, LTD, for example. And then you have changes in the nucleus, which is the more long-term changes with epigenetic changes. So what does that have to do with ketamine? Ketamine was developed in 1962 by Parker Davis Laboratory, Calvin L. Stevens. He previously had developed PCP, and then he developed this new anestheticum. So it was originally not supposed to be a medication to treat depression or to treat substance use disorders, but to develop a new and improved anesthetic medication. Ketamine acts on the NMDA receptor. It's an NMDA antagonist. That's the main glutamatergic receptor. And it acts also on other glutamatergic receptors like the AMPA receptor, where it's an indirect activator. So we do actually see some overlap in the activity of ketamine and alcohol in the individual cell. The question is, how does ketamine work? And here I have a picture which depicts not only ketamine, but psilocybin, sertraline, LSD, other psychedelic medication. And the question here is, how are they related? Because currently we are looking at similarities also in ketamine with psychedelic medication. The question is, from a pharmacological point of view, there is actually not that much overlap as that would warrant to put them into the same group. When we look at NMDA antagonist, there is actually a number of different NMDA antagonists available currently. Methadone, for example, also has an NMDA antagonist activity. But what you can see here is the ketamine, which is an anestheticum, memantine, which is used for dementia treatment, amantadine, which is used to treat Parkinson, and dextromethorphan, which is used to treat cough. When I did research in that area, I mainly looked actually at memantine and dextromethorphan, because at that time, it seemed to be that ketamine, with its risk of hallucination and psychosis similar activity, seemed to be more risky than memantine and dextromethorphan, which did not have these side effects. Interestingly enough, from a different perspective nowadays, that might actually be the factor which differentiates ketamine from memantine and dextromethorphan, and might be the reason why it might be more effective. The other thing is, when you look at these medications, is that they do induce the same symptoms under certain situations which we aim to treat. If you look at ketamine, for example, it can induce depression. If you look at memantine, it can induce confusion. If you look at amantadine, it can induce dyskinesia. So these medications obviously have to be used very specifically so that they do not induce the issue which we want to treat. And I already indicated that the question has arisen, is the effect of ketamine and similar to psychedelic medication due to subjective effects, or can we actually have the treatment outcome without having the subjective effects such as severe psychedelic experience? The other question was that what differentiates recreational drug use from medical indication? When we look at the main substances of abuse, a lot of them are actually used as treatments. Opiates, it's very well known that they're used for pain, stimulants for ADHD, ketamine for pain and as an anestheticum, benzodiazepine for anxiety. Cannabis currently, THC specifically, it doesn't have any indication, but there's a discussion about possibility. Nicotine really is only used for treating nicotine use disorder as a substitution therapy. So it's actually alcohol, which is the one substance which is not used clinically. And then if you look at it, what's the difference between ketamine abuse or recreational use and the medical use? One big difference is that in recreational use that we have self-administration mainly, while in medical use it's plant supervised administration. And we know from animal study that is a huge difference. We also have a different context in which substances are used. Is it a party environment or is it a therapeutic environment? Again, we know also from animal studies that this has an impact on the effect of the substances in which context they are used. And then there is also kind of like differences in the focus on intoxication and the focus on change.
Intravenous ketamine.
Yes. Yeah.
Okay. And the risk of pathological habituation and the change to recalibrate. So there is a difference in setting and integration, but interestingly enough, we have with the majority of the current substances which have a recreational use, also some medical use. Now I want to finish up with currently available treatment for studies which looked at ketamine for alcohol use disorder. And what you can see here, there's 4 published studies. 2 were actually studied more than 20 years ago by Kopitsky in Russia. And what you can see is that he did relatively large studies. They were under very specific circumstances. And he gave relatively high doses of ketamine. It was treatment as usual was a comparison, and he did show reduction in heavy drinking and increase in abstinence days. He did discontinue his studies, not because he didn't think that it's worthwhile to continue with it, but in, I think, 2001, ketamine was placed as a Schedule I medication, so it was not possible to do any further studies in Russia on that. More recently, there have been 2 studies which do show that ketamine may have a clinical value in the treatment of alcohol use disorder. And in the 2019 study, they did 1 infusion. In the more recent study, they did 3 infusion. Both of them are smaller studies. One thing which I want to mention is that in these studies with hallucinogenic and with ketamine, there is a strong selection of patients. So when you look at the standard treatment studies and those studies, these selection criteria are much stronger. And what you can see is there is only small numbers of people who were actually studied. There is a big discussion around ketamine administration and the psychotherapy. What is how big is the need of psychotherapy? How much psychotherapy do we need? Do you need it before, concurrent, or after, or do you need all of it? I want to show you the results from the largest study, which I indicated before, which just came out from Krupski. And what he showed is that he had the percentage of days abstinent in 4 arms, 2 arms with ketamine and 2 arms with placebo, 2 arms with psychotherapy and 2 arms with psychoeducation. And what you can see in blue is that placebo and psychoeducation had the lowest abstinent rate, about 70% remained abstinent within the 24 weeks. And the highest one was actually the ketamine together with psychotherapy. What you can see is that also with psychoeducation, that was the ketamine with psychoeducation was the second highest effect. In each arm, there are about 25 people. Let me summarize. I think it's important that we have just started to study ketamine for alcohol use disorder. Patient selection is very important. It seems to be very important to prepare the patient for the intervention. The context of the intervention is very important. From psychedelic, there's a question, how big is the importance of the integration or follow-up? Then there is a risk associated with people being more vulnerable during these kind of treatments. And I'm talking here pretty much from a psychedelic perspective. And then we know very little so far about the longer-term possible adverse effects, even though they were kind of like really minor in these studies. And we don't have any studies with long-term outcomes so far. Okay, thank you very much.
Thank you, Christian. Now I'm going to pass it on to Dr. Raymond Lamb for the second part of this presentation.
Great, thanks, Christian. That was a great talk. Can you stop sharing so I can share my screen?
Sure.
Okay, let's see. Where is my? Right here. Okay, great. So I'm going to focus on the second valley of death, as Lily mentioned, and use as an example ketamine as a drug for the treatment of depression, which is in a different phase than what Christian was talking about in terms of substance use disorders. Here are my disclosures. And my up-to-date disclosures are always available on my website, drraymondlamb.ca. So we mentioned the 2 valleys of death between basic research through to clinical science and knowledge, and then using evidence-based practices in clinical settings. And so Christian has talked about Valley 1 in terms of getting the clinical research evidence to support the use of a new medication. I'm going to talk about Valley 2, which is how do you, once you've shown the evidence base, how do you bring it into clinical practice? How do you get it into healthcare systems? And again, I'm going to be using the example of ketamine for treatment-resistant depression, because unlike other psychedelics and other disorders like substance use disorder, you don't actually need psychotherapy for ketamine to be useful. It does seem to be effective as a drug. And of course, the first paper to suggest this was actually came out of my good friend and colleague, John Crystal's group at Yale. Robert Berman published this first study looking at ketamine for treatment-resistant depression, where a single IV infusion was significantly better and a rapid-acting antidepressant compared to a placebo in this group of refractory patients. And the effect was actually sustained for at least 3 days following a single IV infusion of low-dose ketamine. Well, since then, there have been a lot of systematic reviews and meta-analyses of different ketamine studies for depression. Alex McGurr, who was a research track resident working in our group, published the first of these meta-analyses at the time, showing clear benefit across a number of studies. In fact, almost every study showed significant benefits. And since then, all the meta-analyses have shown clear evidence that the single dose IV ketamine is, a rapid-acting, effective antidepressant in people who are treatment-resistant. So, the Berman study came out in 2000, and it's often said that 20 to 25 years has to go by before a new treatment becomes established practice. And I think that's certainly the case with ketamine for depression. So one of the important things is, once there is evidence, how do you get clinicians to understand and be able to use the evidence? And that's where clinical guidelines are very important. So for example, our Canadian Network for Mood and Anxiety Treatments, CanMat, has been developing clinical guidelines for depression and bipolar disorder for the last 20 years. They're widely used by clinicians all over the world. And we use an evidence-based approach where we evaluate the quality of the evidence and grade it in terms of quality, but we also overlay expert consensus. And that's very important because it's interpreting the evidence and how it can be best used in clinical practice that's important for clinicians. And so we looked at the use of ketamine in people with major depressive disorder. We used the same rigorous process that we used for our CanMat guidelines and came up with recommendations for its clinical use, summarizing the vast literature to be able to help clinicians to use this treatment. We use a question-answer format for all of our guidelines because that's how clinicians think in terms of questions and the answers to those questions. And so here, this is just the number of questions that we asked and answered by our review of the literature. And just to show you the kind of final recommendations, we obviously make recommendations about the efficacy of the drug in terms of where it's placed relative to other treatments for depression. And you can see here that we grade the quality of the evidence for each recommendation. And we really considered that IV ketamine was the third-line recommendation for people with treatment-resistant depression. And that's because there are a number of established augmentation and other strategies for people with treatment-resistant depression that probably should be used first before considering ketamine. Nevertheless, because all of the treatments are not necessarily very effective for people with treatment-resistant depression, it is important to, ketamine will be an important addition to our armamentarium because it has such a different mechanism of action than the other established treatments. But in addition to recommendations about efficacy, we also gave recommendations on things like treatment settings and personnel. What kind of staffing do you need to use for intravenous ketamine? Because there are side effects, as Christian mentioned, in terms of psychiatric side effects, but also medical side effects with, for example, increased blood pressure in some patients who receive this treatment, as well as obviously the sedative qualities of ketamine. And this is very important, particularly for regulatory agencies like the College of Physicians and Surgeons of BC that has specific standards in place for things like IV medications. And so, these types of recommendations are very helpful for those regulatory agencies as they establish standards for treatment. Well, that's the clinical use of ketamine. But how available is ketamine now that we've established it as a useful and effective treatment for people with treatment-resistant depression? Well, unfortunately, you really can't get ketamine treatment in Vancouver or in the Canadian healthcare system. And the only availability at this point is in private clinics that offer infusions for pain relief. So for example, the Change Pain Clinic offers IV ketamine for depression, but they charge $675 per session. And so for 5 or 10 sessions, which is, the number of sessions you need to be able to show that people have an effect, you can see that there's a significant cost to this treatment that's not paid by the medical system. Similarly, there's a new ketamine-assisted therapy center that started up in Vancouver called Field Trip. Again, similar pricing for these sessions. Again, that is very difficult for many people in terms of paying that cost for this treatment outside the medical plan. Many of you know that intranasal esketamine, the S enantiomer of ketamine, is now available and approved by Health Canada, available for use. But because of issues related to its use, not to mention the cost, which again is about $600 to $900 per session, again for an 8-session treatment course, $5,000 to $7,500 just for the drug alone, makes it a very expensive medication that's not paid for by the medical system. And for intranasal esketamine, like for ketamine, you do need to monitor people for a couple of hours to make sure their blood pressure and other side effects are okay. So it has to be done in a clinic setting. And right now there are no clinics that have the staffing to be able to provide this monitoring. So really, it's not available in our public health system, and yet it's an effective treatment that should be available. And so when we looked at that, our regional mental health and substance use executive here at Vancouver Coastal Health, led by Andrew McFarlane and Dr. Lakshmi Yatham, really wanted to look at bringing a ketamine program to Vancouver Coastal Health. And I'm going to talk about how we did that in terms of bringing it in the next few minutes, because it really illustrates how challenging it is to bring a new novel intervention into a publicly funded program. So they established a work group, which was chaired by myself and Courtney Devane, a project manager with Vancouver Coastal Health. And we established a project steering committee, which included representatives from many stakeholder groups that would be important in terms of bringing a new program into Vancouver Coastal Health. And so this steering committee was comprised of over 35 members representing psychiatry, but also the operational side of Vancouver Coastal Health, managers, nursing, anesthesia, etc., as well as including people with lived experience from our family and patient advisory group. We had some peer advisors and family advisors in this group. We also included ethicists. So the VCH ethics department also were a part of this group in order to really provide some ethical guidance, because we knew we had to limit the use of this treatment. We didn't have funds, obviously, unlimited funds. And so we thought it was important to include ethicists as we talked about how we would kind of deliver this limited program at Vancouver Coastal Health. You can see that there were a large number of tasks, very established types of tasks to bring a new program into the into Vancouver Coastal, not just in terms of the clinical use, but also in terms of budgeting. Very important in terms of finding a budget for a new program, because as you know, we have a limited budget. It's a a zero-sum game, unfortunately. If you bring in a new program, it means that something else has to be, those funds have to be found within an existing budget. So what we did in terms of this work group was really to focus on two important documents. One was an administration protocol that would very clearly outline how IV ketamine would be used within a Vancouver Coastal Health facility. And again, this was based on clinical guidelines like our CANMAT guideline, and established by consensus with all of the groups that included things like, what kind of nursing supervision was needed, what would be the inclusion-exclusion criteria, etc. And then importantly, we also looked at a business case. And this is something, of course, that many clinicians and clinical researchers don't really appreciate, but it's really looking at the economic argument for adding a new program into the established clinical facilities at a healthcare authority. Very important, the business case. I'm going to talk a bit more about the business case. This was established with of course, an economist, not an economist, a manager who was familiar with budgets. And what we did was we looked at ketamine use, and we actually looked at the benefits of ketamine in relation to other non-medication treatments for treatment-resistant depression. And that included electroconvulsive therapy, widely used for treatment-resistant depression, widely regarded as the most effective treatment for people refractory to other treatments, and repetitive transcranial magnetic stimulation. And so we compared ketamine to these other treatments for depression in terms of efficacy, safety, access, many other important considerations, and costs. And one of the main critiques about our Canadian public health system, of course, is that it's very difficult to figure out how much anything costs. We have block funding. It's very arcane to figure out what a procedure should cost. And so these are all estimates. Some would say guesstimates, but they're certainly based on the available information that we had. And so just to cut to the final bottom line, as it were, here's our analysis in terms of the cost of the three treatments. The capital costs are the infrastructure support. So ECT requires a machine, requires electrodes. Same with RTMS, requires a machine. So the capital costs are much higher for ECT and RTMS than for IV ketamine. And so we can estimate, based on nursing and anesthesia requirements, psychiatrist requirements, the cost for a single session of each of these conditions. And you can see the amounts are available there in terms of single session costs. And then the cost of a course of treatment, which for ketamine is between 4 to 6 sessions for an acute treatment. For ECT, 6 to 12 treatments. We costed it for 6 to 8 treatments. And for RTMS, 20 to 30 sessions of RTMS. And you can see the costs here, that the costs for IV ketamine are about the same as the cost for RTMS, much lower than the cost of ECT for this condition. So even though we don't have a lot of comparative studies of these three treatments, it does appear that IV ketamine, really has a reasonable cost compared to some of these other treatments. And our recommendations is that VCH and Providence Healthcare really should provide some equitable access to IV ketamine for people with treatment-resistant depression across the region. And I'm pleased to say that the executive of Vancouver Coastal Health, not just the psychiatry executive, but all the way up to the senior executive, also agreed with these findings and have approved a budget for a pilot program in a couple of sites to really, see where this treatment fits in terms of the healthcare system. So that's the important aspect of trying to get a new treatment into the public health system. I just want to finish by mentioning that we're looking to try to make it simpler by using subcutaneous ketamine instead of intravenous, because that's much easier to administrate. And this was led by Joseph Tam in our neuropsychiatry program. We developed a protocol for subcutaneous and intramuscular administration. We examined the effectiveness in an open label treatment of 10 patients that we published, showing very good results, with results very similar to what's seen with intravenous infusions, but much more feasible to do in a busy clinical setting. So just to finish up, I just want to, summarize by saying, ketamine is a novel, but now evidence-based treatment for treatment-resistant depression that's not really accessible to most patients. And that clinical implementation of these novel interventions requires a lot of knowledge translation addressed to both patients and clinicians in terms of how to use a new treatment once it's become an evidence-based treatment. And in particular, there needs to be a lot of knowledge translation with a different skill set in terms of looking at implementing these novel interventions in a publicly funded healthcare system. Thank you very much. Happy to go over questions.
Thank you, Dr. Lam.